bodies formed, eaten away by macrophages, inflammation, absent, inflammation present. Okay, so quickly we are going to move on to the next topic, inflammation. Inflame, flame. The word is inflame, which is derived from flame. Flame is red and hot. So area affected by the inflammation, acute inflammation, is red and hot. Okay. Whenever you want to imagine or rut out the cardinal signs of inflammation, always imagine a boil. This is a boil on the inner surface of the thigh. What we see first is rubor, the redness. Second is what? Tumor or the swelling. This area is swollen. Calor means heat. Calor is derived from, what is the unit of heat? Calorie. That is where the word calor is derived. If you really measure the temperature, it is going to be hot. Dolor is pain. Functio lisa is the loss of function to that particular place. These are the cardinal signs of inflammation which are prominent in acute inflammation. What is a definition? It's a complex reaction which is basically involved as a defensive mechanism. Please remember, very important word, defensive mechanism in a vascularized organism. Why vascularized? If the blood vessels are not present, the blood soldiers of the body, leukocytes are not present, then the blood vessels cannot carry the leukocyte to the place where the injury has occurred and the inflammation cannot take place. So it has got to be in a vascularized organism where the injurious agents can be physical, chemical, biological, or immunological are there. So these are the ones against which the defensive mechanism operates, and it involves the vascular response, migration of leukocytes, and also the systemic reactions. Please remember the difference between infection and inflammation. Inflammation can be caused by physical, chemical, biological, and immunological injuries, right? Infection is only because of the biological microorganisms are causing infection, but the inflammation can be caused by all the different causes. Systemic effect of inflammation: fever, elevated acute phase proteins, leukocytosis, and other manifestations are also there, which are usually carried out by the tumor necrosis factor, interleukin 1, 6. These are the mediators. Of the elevated acute phase protein, C-reactive protein is very important. Basically, paradoxically, they are called acute phase proteins, but they rise in chronic inflammation synthesized by liver, and the level of high sensitivity CRP, C-reactive proteins, is measured for the ischemic heart disease. We know atherosclerosis is now considered to be a chronic inflammation. So whenever the atherosclerosis is developing, which may lead to ischemic heart disease, the levels of the high sensitivity CRP are high, so that is more important. Serum amyloid A, we know it is involved in amyloidosis, that also increases. They help in eliminating microbes and other features. The neutrophil increase in seen classically in bacteria, most bacterial infections, exception Salmonella. Okay, enteric fever, there is neutropenia. Most of the viral diseases, lymphocytosis is there. Most of the allergy cases, eosinophilia. Eosinophil is equal to allergy. Inflammation is a double-edged sword. Basically, it evolved as a protective phenomena. Without inflammation, infections will proceed unchecked and may cause death. However, if unchecked, it will cause harmful effect, will cause diseases like rheumatoid arthritis, lung fibrosis, atherosclerosis. That's why we use the anti-inflammatory drugs like the aspirin, steroids, and the brufen. This is a picture of rheumatoid arthritis where small joints are affected. The cartilage is lost because of the necrosis, replaced by fibrotic process. Fibrotic process always shrinks, so you have crooked fingers. Here is the fibrosis, which is because of tuberculosis, second bad effect of inflammation. Basically, in the mechanism of inflammation, what is the story? It is basically a battlefield in which soldiers of the body, the WBCs, which are normally present inside the blood vessel, are carried by the bloodstream to the place where the attack has occurred. And from inside the blood vessel, they move out to the interstitial space, and in the interstitial space, they further travel according to the chemotaxis to a place where that injury has actually occurred. Okay, so this is basically the soldiers of the body, the WBCs, being carried to the place where the injury has occurred. Vascular events. What are the vascular events? Foremost is vasodilatation, persistent vasodilatation. One of the earliest manifestation which is seen all types of injury. Please remember vasoconstriction, transient means for some time only. Transient vasoconstriction occurs in only few instances like burns. It does not occur in all injuries. Please do not write vasoconstriction and omit vasodilatation. You can do the vice versa. So persistent vasodilatation is very important so that more blood goes to that particular place. Along with blood, more soldiers of the body, WBCs, go to that particular place. Okay, this is induced by histamine, bradykinin, nitric oxide, and the result that we see clinically is heat and redness in the inflamed area. Then there is increased permeability of the microvasculature, outpouring of the protein-rich fluid, loss of fluid from inside the blood vessels, increased red cell concentration, increased viscosity of the blood. Naturally, blood will slow down. It will move slowly. Stasis will occur. Third change is stasis, where the neutrophils, the WBCs, they will be lined according to the on the lines of the on the sides of the endothelium. They will be in the periphery. Increased permeability. Why it is caused? Increased permeability, basically loss of protein-rich fluid occurs. Okay, that leads to edema. Increased permeability leads to edema. We will see why they occur in the next few slides. Here, what happens is protein-rich plasma is lost from inside the blood vessel. So there is decreased oncotic pressure inside. What is oncotic pressure? Pressure exerted by the solids. Osmotic pressure is exerted only by electrolytes. Oncotic pressure is exerted by all solids. And the main solid in the blood is a protein, plasma proteins. That is lost. So oncotic pressure inside the blood vessel is less. That in the interstitial pressure is more. Then more blood is flowing through the dilated blood vessels. So the hydrostatic pressure inside the blood vessel is more, and it is as compared to the hydrostatic pressure outside. The hydrostatic pressure will push the fluid out, and the increased oncotic pressure outside the blood vessel will attract the fluid from inside the blood vessel. So net outflow of the fluid is there outside the blood vessel, which will give rise to edema. At both the venular and the arteriolar end, we are finding net outflow of the fluid, which is causing edema and the swelling, tumor. Mechanism of increased permeability. Why does it occur? Increased permeability. First is the immediate transient response. Immediate, as the name suggests, starts rapidly. Transient lasts only for 50 to 30 minutes. Why it occurs? Formation of gaps between the endothelial cells, okay, of the venules. Capillaries and arterioles remain unaffected. Venules are the ones which are affected, usually mediated by histamine, bradykinin, glucotrienes, and neuropeptide substance P. Immediate sustained response. Second one is immediate sustained response. Immediate starts immediately, lasts for several hours until the damaged vessels are either repaired or thrombosed. All the types of vessels, venules, capillaries, arterioles are involved. This is because of direct endothelial injury. Why the injury may occur in severe burns or bacterial infections, which are going to lyse the endothelium because of toxins, the septic shock as we call it. That is where it comes in. Because of the injury to the endothelium, either thrombosis will occur or the blood vessels will be repaired and the response will stop. Next one is a delayed prolonged leakage. As the name suggests, starts 2 to 12 hours, delayed, isn't it? Lasts for several hours. It involves both venules and capillaries. When does it occur? The X-ray radiation, ultraviolet radiation, sometimes in bacterial toxins, late appearing sunburns. Whenever we are giving radiotherapy to a cancer patient, after the radiotherapy, after a few days, this particular edema will occur, and that is because of the delayed prolonged leakage that is going to happen. Mechanism is not very clear. It may be because of the apoptosis, which occurs because of the radiation to the endothelial cells, or maybe because of receptor-mediated formation of gaps in the endothelial cells. Next is leukocyte-mediated endothelial injury. Leukocytes are sticking to the endothelium. They get activated and release the enzymes, proteolytic enzymes, and damage the endothelium. This occurs only in pulmonary and glomerular capillaries, where the leukocytes are adherent to the endothelium for a very long time. Lastly, leakage from the blood vessels. We know repair process is proceeding where the granulation tissue is formed, which starts with new blood vessels, neoangiogenesis. These new blood vessels are immature and leaky, so more fluid goes on. So all these are the different mechanisms by which there is increased permeability of the blood vessel. All these are not described separately. They may occur simultaneously in different forms. Okay. So now we must also know the difference between transudate and exudate. Why it is must to know this? Because basically exudate is always inflammatory, while transudate is non-inflammatory. Let's say a person is suffering from tuberculosis and he has got pleural effusion. There is fluid in his pleura. Okay, the doctor taps the fluid, takes out the fluid and sends it to the laboratory. What we find is there is, if it is an exudate and contains lymphocytes, 95% in India we are certain that the pleural effusion is because of tuberculosis. While if it is a transudate, then what we are certain that it is not because of an inflammatory process. Most likely it is because of congestive cardiac failure. So the differences, as we have seen the cause here, the hydrostatic pressure is increased as it occurs in CCF, exudate, inflammation is present. So gaps are there, proteinaceous fluid comes out. So appearance because of the presence of protein, cloudy in exudate. The protein specific gravity is also more because of, again, the protein content, which is more than 2.9 here, less than 2.5 out here. In between, indeterminate. In between, indeterminate. There are certain ratios which are derived. More important is inflammatory cells which are present in the exudate because it's inflammatory in nature. Serum LDH is more in the exudate. Cholesterol is more in the exudate. Radio density on CT scan. This is for the high flow PG students. Mainly, we should know clear appearance, specific gravity, protein content, and the inflammatory cell to differentiate between the transudate and exudate, the importance of which we have seen. The lymphatics and the lymph nodes. Lymph nodes are immunological filters, so they are also involved. They are draining the interstitial fluid. They are also involved in the inflammation of the lymphatics will cause lymphangitis. That of the lymph node will cause lymphadenitis. Cellular events. What is happening to the soldiers of the body? Leukocyte extravasation. They come out. There are different stages involved. Chemotaxis in the interstitial space. They will travel towards the focus of injury. They get activated, ultimately eat away the injurious agent. Sequence of events when they are going out is basically first is what? Margination. What happens is, as it is, the WBCs are lying outside near the endothelium as compared to the RBCs in the normal flow also. Outside this is, of course, the plasma which is flowing in the laminar flow. The more number of WBCs, they migrate to the periphery, to the margin, and also traverse the plasma and begin sticking rather, I should say, to the endothelium. This is what they go to the margin called margination. They start rolling around the margin, which is called rolling. They're transiently adhering. Ultimately, they adhere. They get fixed to the endothelium permanently. Then it looks like pavementing. Pavementing is what? The entire surface of the endothelium is covered by neutrophils. This is a pavemented wall. These are the tiles which are covering the walls. The neutrophils will be covering the wall. This is a pavemented footpath. The tiles are covering the footpath. So pavementing by the neutrophils means that the entire surface of the endothelium is filled with the neutrophils. Then transmigration occurs. They just jump out from inside the blood vessel to outside. That is also known as diapedesis. Then chemotaxis. They travel according to the gradient of chemical gradient towards the place where the injury has occurred. leukocyte get activated and ultimately they will eat away the bacteria or the injuring particle. What is a molecular basis? Molecular basis, why should this all happen? Because of the adhesion molecules and because of chemoattractants. The adhesion molecules which are present on the leukocyte are the Chialin Lewis X, integrin, and CD31. Here what we see, this is a leukocyte, Chialin Lewis X is present, integrin is present. What we will see out here will be also the CD31 molecule. Okay, and the corresponding molecules which are present on the corresponding molecules present on the endothelium, P-selectin, Chialin Lewis X, combination with P-selectin, transient adhesion rolling, combination with E-selectin, rolling and adhesion, combination with ICAM and VCAP, firm adhesion. Ultimately, combination of CD31 with PCAM, which is present on the endothelium, will give rise to the flipping over or the diapedesis. Okay, so what we see out here is the rolling is occurring, E-selectin, P-selectin, they are combining with Chialin Lewis X. Here, their integrin is combining with ICAM, also VCAM is present. So firm adhesion has taken place. Ultimately, the PCAM has combined with CD31 and the leukocyte has moved out. Once it comes in the interstitial space, it secretes enzymes, fibrinolytic enzymes, which will digest the fibrin and the fibronectin, which is present in the interstitial and travel in the interstitial tissue. They also release chemokines, which will activate the WBCs, and cytokines, which are released by the macrophages, which will be acting on the endothelium. So basically, the microbes and the dead cells, they come in contact with macrophages. They secrete chemokines like tumor necrosis factor, TNF, and the interleukins. And these are the ones, TNF and the interleukins, which control the secretion of these adhesion molecules. These are controlled by the chemokines. Here is a picture, histomorphological picture, where the leukocytes have come out into the interstitial space. These are the muscle fibers that we see here. Here is a blood vessel, which is dilated. We can see margination of the leukocytes. Then we come to chemotaxis, basically the locomotion oriented along the chemical gradient. Whenever certain chemicals are more in concentration, leukocyte will travel towards that particular place. Okay, so basically, what are the chemoattractants? Chemoattractants are the products from the bacteria like that we have the peptides N-formyl, methionine, others are lipids, and endogenous products like we have the anaphylactotoxin C5A from the complement system, and also that we have the leukotriene B4 and the cytokines like interleukin 1 and interleukin 6. Interleukin 8 is also involved in the process. Leukocyte activation, basically microbes, products of necrotic cells, all these act upon leukocytes and they're activated. They become more capable. They become more capable of forming the, they become more capable of performing their functions and eating the phagocytosis. Okay, so basically killing of degradation, basically what happens is there are certain mannose receptor and the scavenger receptors located on the leukocyte which recognize particles which are supposed to be ingested. So these are the receptors and there's a particle to be ingested. They recognize them. The particle is engulfed. This forms a phagosome. The phagosome combines with lysosome to form the phagolysosome, and the contents of lysosome, which are the proteinaceous enzymes, cathepsins, even the oxygen-free radicals, all these are then released into the phagolysosome, which will digest this particular organism. Termination of inflammation is necessary because it can cause damage, isn't it? So inflammation is terminated simply because the mediators have very short life, half-life is short, they are degraded after they are released, and they are produced only till the stimulus which causes the inflammation lasts. And of course, there are certain genetic stop signals which are given right from the beginning when the inflammation starts. Coming to the last part of today's lecture, we'll come to thrombosis. Thrombosis, when the God made human being, he had a dilemma. He had a dilemma. Blood should normally be liquid and should flow, isn't it? Otherwise, the body will not get the nutrients. The different parts will not get the oxygen. And it should clot if there is an injury. If it does not clot and the hemorrhage is not stopped, what is going to happen is the blood will flow out. There will be hypovolemic shock and the person will die. So basically, he brought out two systems. One which maintains the blood into the fluid state. The other one which forms the hemostatic plug or the clotting. Balance between these two is going to affect the outcome of that particular situation. Maintenance in the clot-free state, intact endothelium. Intact endothelium is very much necessary. If the endothelium is injured and the subendothelial matrix is exposed, injury to the endothelium and subendothelial matrix is exposed, then the platelets will go and stick to it. Von Willebrand factor. If you remember, von Willebrand factor acts as a glue between the platelet and the endothelial membrane. They will go and stick to the subendothelial matrix, and there will be the platelet adhesion and activation, and a platelet plug will be formed. Ultimately, clotting mechanism will be activated. So intact endothelium is very important. Then there are antithrombins. Prototype is antithrombin 3, which acts against thrombin factor 8, 9, 10, and 11. Basically, these are the secreted so that the clotting mechanism is controlled after the need for clotting is over. Then there is another system, plasmin system, in which plasminogen activator, which is present either in the blood or in the endothelium, will convert the plasminogen into plasmin, and plasmin is the enzyme which will go and lyse the fibrin. Fibrin is the ultimate thread which is formed in the clotting mechanism. So what we have is definition of thrombus. We have seen preliminary what are the factors which are involved. Basically formation of clotted mass of blood in uninjured or uninterrupted cardiovascular system is known as thrombosis, and the mass itself is known as thrombus. Please understand that injury occurs, clot is going to be there as it is. Okay, there is nothing great about it. That is not a thrombus. Okay, but at the same time, the endothelium is injured, which is minimal injury or a subtle injury. No actual disruption of the blood vessel occurs. If the disruption occurs, clot is normal. Without the disruption of the blood vessel, in uninterrupted or uninjured blood vessel, if the clot occurs, we are going to call it thrombosis. Thrombogenesis, what is the pathophysiology behind the formation? Pathogenesis, what we have is the Warsaw stride. The gentleman Warsaw, very famous scientist, he gave the 3 factors which cause the thrombus. Endothelial injury first, stasis or turbulence of blood flow, and third is hypercoagulability. So what we have is Warsaw stride component number 1, endothelial injury, which you have already talked about. Okay, this is the most important cause, only one which itself can give rise to thrombosis. Thrombi occurring in ulcerated, some examples when it occurs in the ulcerated atherosclerotic plaques. Okay, injury has occurred to the endothelium because of atherosclerotic plaque. This is the atherosclerosis in the aorta. What we see here, this is normal atherosclerosis, advanced atherosclerosis, type 4, last stage of the atherosclerosis, where the ulcers have formed. These are the injury which has occurred. So naturally, platelets will go and stick there and start the thrombogenic process. Okay. Second example is myocardial infarction. Basically, myocardial infarction, there is necrosis of the muscles and also that of the endothelium. Injury to endothelium, platelets will start sticking, and we will have the formation of thrombosis. Myocarditis, inflammation of the myocardium. Same thing is going to happen. Similarly, inflammation of the endothelium of certain arteritis, the inflammation of the arteries that we are going to see. Certain subtle injuries like mechanical injuries, hypertension, blood pressure high for number of years. Okay, it is going to cause a subtle injury to the endothelium. Similarly, toxins from the bacteria, We all know cholesterol, high cholesterol causes problems. So hypercholesteremia, cysteine, homocysteine, isn't it? That is also known to be a causative factor or an indicative factor for the ischemic heart disease and atherosclerosis. The products of smoking, all these are the chemical injuries, these are mechanical injuries, all these are ultimately going to cause the subtle injury to the endothelium, which is going to initiate the process of thrombus formation. Second one is the second factor component is the stasis and turbulence. What is stasis? Stasis is when the blood flows slowly. And what is turbulence? When the currents are formed in the blood, like this is a turbulence occurring in the water. Similar turbulence can occur in the blood. Here also currents are forming, that is what is turbulence. Normally there is laminar flow of the blood where formed elements of the blood, RBCs, WBCs, they're in the center, plasma is at the periphery. What happens because of stasis and turbulence? This laminar flow is disrupted. Dilution of activated clotting factors is prevented. The clotting factor inhibitors, they do not come there. It also permits the build of platelet aggregates. There more platelets are there because of stasis. Okay, turbulence itself will cause the injury. Basically, stasis will cause the dilution factor prevention, more inhibitors not coming in, and platelet aggregation. While turbulence will cause the injury. Okay, examples of turbulence behind the veins, the valves of the veins, isn't it? We know veins are what? Behind them, there can be turbulence, auricular appendage in the heart, in the atrial fibrillation, when the heart is beating slowly, 72 beats per minute, fully it is contracting. When the heart rate increases to 200, more than that, then the heart just shivers. Okay, so there is a stagnation of the blood there. Aneurysmal dilation. What is aneurysm? The blood vessel itself dilates and forms a sac-like opening. So blood just circulates out there and forms currents. That is aneurysmal dilatation. We will see turbulence. Stasis is this is more important in the case of arterial thrombus. Okay, turbulence more important in the arterial thrombus. Stasis most important in the case of venous thrombus. Arterial thrombus and venous thrombus both act differently. The venous thrombi will give rise to venous emboli, which will go along the venous system to right side of the heart and will be trapped into the lungs and will cause the damage in the lungs. While the arterial thrombi will go into the systemic circulation and will cause the ischemia of the tissues in either the liver, spleen, brain, maybe the limbs. Okay, so that is very important. The venous thrombi, the stasis is the most important factor. Why stasis occurs? Because of the immobility. Some patient is bedridden, somebody is in coma, he does not move his limbs. Actually, how does the blood travel? Blood travels in the arteries because of systole in the heart. It moves forward. Once it goes to capillaries, then it travels slowly. Then the muscles, peripheral muscles, they contract and the blood travels back. Because of stasis, the muscles will not contract, blood will not travel, stasis will occur. Here is aneurysm where the turbulence is important. Then third factor is hypercoagulability, which is seen usually as inherited lack of antithrombin, maybe disseminated cancer, very important. Surgeon operating on disseminated cancer should take precaution. Late pregnancy, the hypercoagulability, maybe there's females taking the contraceptives. They are also liable to thrombosis. Morphology, arterial thrombi, they originate at the endothelial injury site towards the bifurcation of the arteries where the turbulence is more. That dry, tangled, friable gray masses section shows lines of Zahn. What are lines of Zahn? Alternating RBCs. These are the fibrin, which is deposited, RBCs deposited. So lines of Zahns are there in the arterial thrombi. Mural thrombi, large capacious vessels, they're attached to, they don't occlude the thrombi, they occlude. Venous thrombosis, invariably it is occlusive. They occur in the lower extremity, deep cuff, femoral, popliteal, iliac veins, they will occur. They look red in color. They are red in color. They form the cast of the veins. They are being formed in lines of Zahn are not prominent here. Okay, they got to be differentiated from two things: arterial thrombi from the venous thrombi, and the venous thrombi from the post-mortem clot, the blood which has clotted after the person has died. Very important examination questions. So what we see, arterial thrombi on gross examination, they are gray, white, friable, laminated by lines of Zan. Venous thrombi, red, blue lines of Zan are absent. The arterial thrombi develop in mural or occlusive. They are invariably occlusive. At the coronary, aorta, cerebral, mesenteric arteries, arterial thrombi develop. Well, deep veins of the leg is the favored site for the venous thrombi. The causative factor is damage to the endothelium. Here the causative factor is the thrombophlebitis or the stagnation of the blood. Ultimately, the venous thrombi go and damage the lungs. The arterial thrombi may also form the emboli, which may go into the systemic circulation. Postmortem clot in the venous thrombi, both form cast of the veins, both are rubbery and gelatinous. Venous thrombus is more firm. Both the venous thrombus is attached to the wall. Here it is not attached to the wall. These three criteria may not conclusively differentiate. What conclusive differentiation is because of the dark red currant jelly and chicken fat. What is this concept? Basically, what happens is a person dies, then the blood solidifies. It is not actually a clot, it is a solidification of the blood. Because of the gravity, the RBCs will precipitate down. So down below, what we find is the red precipitated RBCs, which is called dark red currant jelly. And on the top, we will find a cloudy plasma. Plasma contains protein, so it will be cloudy. It will look like chicken fat. So in the postmortem clot, when we open the veins, what we are going to find is dark red currant jelly because of the RBCs at the bottom, and chicken fat because of the proteinaceous plasma which is on the top, which is absent in the venous thrombosis. Heart valve vegetation seen in the infective endocarditis, where the bacteria grow on the heart valves, not only colonize, grow on the heart valves, like they go in petri dishes, which you have seen in the microbiology lab. What is the fate of thrombus? Versus propagation. It increases in size and may obstruct. It may embolize, may form a piece of the thrombus, make it detached and may travel along the blood and may block the blood vessel somewhere and cause ischemia in the distal part, or favorable removal by fibrinolytic activity. Doctors may give certain medicines like streptolysin or naturally occurring plasmin that may lyse the fibrin which is in the blood clot in the thrombus, and the fibrinolytic activity may remove the thrombus in the organization and recanalization. Basically, repair process is going to start. Granulation tissue, subendothelial smooth muscle, and the mesenchymal cells will migrate into the thrombus, and they will form channels. They will form these channels. See, these channels are there, capillary channels are there. Again, this is a thrombus in which channels are forming. Recanalization is occurring. These are lined by the endothelium, and the blood will flow out of it. Okay. Lastly, these channels will just anastomose together and entire lumen may open. Lastly, clinical correlation, venous thrombi, occlusive, and immobility, bed rest, post-operative, most important causative factors. So you should take precaution. The patient should be mobilized immediately. Arterial thrombi may predisposing causes are myocardial infarction, atherosclerosis, aneurysmal dilatation. They may go as the emboli and block the vessels in the brain, causing stroke, or in the heart, causing myocardial infarction, or kidney, spleen, causing the infarctions there, or in the leg, may cause the